my rights away.
Joy 99.7
I
FM.
will run. You can deny me. You can decide to turn your face away. No matter, 'cause there's something inside so strong. I know that I can make it, though you're doing me wrong, so wrong.
Joy 99.7 FM.
Oh no, something inside so strong.
Yeah, good afternoon to all.
Oh, something inside
209, a bit late. Sincere apologies. But it's complete when I'm in the seat, right? By His grace. Ultimate Health on Joy 99.7 FM with me, Nortey by nature. Got this one in the background.
I will sing
Claudius Afolabi, Cifre 1987.
of Jericho.
Definitely something inside so strong keeps us here.
Our lives
Brings it back each and every Sunday, 2:05, we're alive.
deny my place and time.
Joy
You squander
99.7
wealth,
FM.
that's mine. My light will shine so brightly it will blind you.
That's
'Cause
right.
There's something inside so strong, so strong. I know that I can make it.
Well, on the heels of that, I welcome you to Ultimate Health, your ultimate guide to healthy living. Listen every Sunday, 2:05. Last week, we started the journey to understand sleep.
Something inside so strong.
A very, very, very important, crucial, non-negotiable neurophysiological state of semi-consciousness. We had in the studio with us Dr. Samuel
Not good enough.
Asomani, a resident in respiratory medicine with the Department of Medicine and Therapeutics, Kolebu Teaching Hospital,
Just look 'em in the eyes and say
and a physician specialist as well.
anyway.
We continue today. We want to understand the assessment and management of these sleep disorders. What makes it a disorder? Is it not just a bad night? That's what we're trying to find out. So what is the, clinical diagnosis? What are the types of disorders? What type of disorder perhaps are you suffering from or afflicted by? That's what we're talking about today. Any questions, concerns, welcome. WhatsApp is 055 11 11 997. We're live on Facebook and YouTube. Ultimate Health in Effect. Doc, good afternoon.
Good afternoon.
Right, apologies. On those days when you are hot, that's when you get a tow truck, and that's when you get all sorts of hiccups and all the traffic lights catch you. But it's great to have you to continue.
Thanks for having me.
Right, last week we got to understand what sleep was. We understood that it is pre-programmed, controlled primarily by the brain, and it is supposed to happen. It follows a certain cyclical pattern we can call the circadian or sleep-wake pattern. Right? And then it has certain features. There are times when we are, in light sleep, right? And therefore we haven't lost that much consciousness, but we progress gradually into deep sleep. Stay there for a while, and then about maybe 1.5 hours later, we come back to lighter sleep in cycles of about 4 or 5 during the recommended normal span, which would be about 6 to 7 hours, right?
That's right.
Okay, so we're on track.
Right.
Okay, then we started to understand what kind of things can make this pattern go wrong. You mentioned a few of them. Can you just recap for us?
Right. So, as we said, averagely people do about 7 to 8 hours,
Okay.
adults. But it's not everybody who is able to do this. So a number of things can affect the duration and then also the quality. And therefore, a number of conditions that affect this type of sleep, especially in a long-term basis, because every now and then somebody may just have a bad night, and that's all.
Okay.
But if it becomes repetitive and therefore affects your quality of sleep and affect ability to keep awake especially the next day, and therefore affects your function, then becomes a disorder.
Okay.
Yes.
Right. Now, for certain, diagnoses or conditions, we know that you, the clinicians, have a pretty specific criteria that you're looking to meet before you say somebody has X or Y sleep disorder. So is there anything like that you use as your threshold to say this person has a sleep disorder in this presentation and for this duration, and therefore we say it is a significant disorder?
Very well. So, as I said, there are different levels of sleep disorders.
Okay.
And therefore, the diagnosis required for each of them will vary.
Okay.
Yeah. So, currently we have about, the current international classification of sleep disorders. They group all the disorders into about 7 groups.
Okay.
And in all these 7 groups, more than maybe 80 entities could be appreciated. And
Right.
in each of these 7 groups, we need certain criteria to be able to say that this person has this type of disorder or that other type.
So we'll
of
probably
disorder.
get down to those specifics, right?
That would be fine.
But most people are quite familiar, and it seems to be the most prevalent or frequent sleep disorder we know: insomnia.
Very
right?
well.
Difficulty getting to sleep, staying asleep, waking too early, and a range of other pretty troublesome presentations, right? With that, for example, if I have a difficulty in any of these areas, how often should I experience this difficulty, and for how long must it be there before someone like you says, I have insomnia or a sleep disorder of that type?
Very well. So if, let's say, just once you have this happening, it may not be because you get back to your normal rhythm. But some people, almost every night, they have that problem falling asleep or maintaining sleep. And when they wake up, they have to keep, awake till the next day, and it affects everything they do. And so long as that continues and affects your function, especially, in a particular domain, definitely that is a time to seek help, and that is when we will be very interested in.
Okay.
So we need to talk to the person and then get some answers and feedback, and that will direct us to know what really is happening.
Okay.
Whether this person will really qualify for this type of disorder or not.
Okay, so Doc, you are interested in what is happening to the person, right?
Yes, right.
And what is happening to their sleep.
Exactly.
Okay, and you're also interested in whether it is impairing their functioning.
Functioning, very well.
So you're looking for impairment.
Very well.
Right?
Very well.
And then you are looking at other things before you conclusively say that this person has a sleep disorder.
Definitely.
Okay, right?
Exactly.
Okay, so what's happening to you? What's happening to your sleep? Are you getting to sleep as you should?
Right.
Last week we mentioned sleep latency, how long it takes you to fall asleep when you're ready for sleep.
Yes.
And you mentioned a certain cut-off.
Right.
Can we just go over that?
Right. So some people, it varies. But definitely if you are staying more than over 20 minutes in bed, then probably it's getting too prolonged.
Okay.
And that means that person probably may have to, reverse the cycle. Usually we advise that when it's delayed like that, 20-30 minutes, you are not falling asleep, and it begins to get a visual cycle. You get worried, you are looking at the watch and looking at the time, you are falling asleep. It means that you probably have to get out of bed and so on. But so roughly varies. But if you are staying in bed for about, say, 30 minutes, that may be too much.
Okay.
Yes.
So within 15 to 20 minutes, you should have fallen
More
asleep.
people around that, when they really want to sleep around that time could easily fall asleep.
Okay. Right. 17 minutes past your hour, 2 on Joy 99.7 FM. The program, as always, on a Sunday afternoon is Ultimate Health, your ultimate guide to healthy living. This and every Sunday, 2:05, we come alive. Yes. We wake up, we're alive and conscious. And today we're talking about sleep and sleep disorders. This is a continuation, right? Last week we started with Dr. Asomeni. We're trying to get the basics and then try to pin down how is your sleep problem assessed before we can even type it and say you have X or Y. And then we'll get to the management or treatment of it. Many of you quickly, in fact, there's a big booming industry, millions of dollars for sleep producing agents, sedatives and all that, and all sorts of other things that are claimed, if not licensed, to produce or facilitate sleep. So we want to understand what is going wrong, how is it assessed, who should be assessing it, and then of course the types of and modes of management that are available. If you have any questions, concerns, WhatsApp is 055 11 997. We're live on Facebook and YouTube. This is Joy 99.7 FM Ultimate Health. So, Doc, coming back. So, let's say I believe I have insomnia. And in my long intro, I mentioned difficulty falling asleep.
And or maintaining sleep.
Yes. Right. Those are the cardinal pillars we're looking at.
Very well.
I should have the capacity, all things being equal, to fall asleep.
Yes.
After a working or a day of exertion.
That's right.
Okay.
Or physical activity. Able to maintain it, adequately enough.
And
to get
I should be able to maintain the sleep.
Yes.
To get the adequate sleep required. Okay.
Yes.
Any challenge in these areas, then there is a problem that needs to be looked at.
That's right.
Okay.
That's right.
Right. So there are those who have, I've seen something called early onset insomnia.
Right.
I've seen something called middle or mid onset insomnia. Right. Can we talk a bit about those?
Right. So if you like, maybe for simplicity, people who take a long time to fall asleep.
Okay.
So that's like initial.
Right.
Okay. And then some people, they're able to fall asleep, get up, and then they can't go back to sleep. So if you like, maybe terminal.
Okay.
And then some people have total insomnia. They don't fall asleep.
They don't sleep at all?
Yes, some people.
Is that possible?
Yes.
Physiologically?
Yes. In fact, physiologically, you can maintain that for a number of days. But some people suffer almost near total insomnia, where they don't sleep at all.
Okay.
Yes.
Right. So any, should I say, difficulty in these areas is of concern,
especially when it's not just one off, but it's maintained, it's affecting your function, and sometimes over time it will affect your health.
Okay.
Yes.
But Doc, what if it's accompanied by other things or circumstances? Let's say I'm bereaved. Let's say I've lost a huge chunk of money through debt exchange, or let's say I'm pregnant, or I have some other physical condition. Would you still be looking at insomnia as the significant thing?
Yes, so there are certain precipitants. And for instance, this situation you mentioned, there's something we can clearly pinpoint.
Okay.
Right? And sometimes if you manage the circumstances leading to it, the person probably can go back to normal ways of sleep.
Okay.
Right. And if it becomes too much, then some help may be needed.
Okay.
For a short course, as long as that particular situation is pending. But some people may not necessarily have any immediate, pressure like that. Apart from, as we said last week, different causes. Somebody may have underlying medical condition for which they are unable to fall asleep, or their sleep is interrupted, and when going back to sleep becomes a challenge. Somebody may be on treatment where they have to get up every now and then, go, pass some water.
Okay.
And then once they come back, it becomes like a nightmare. They can't fall back to sleep again. So there could be other circumstances leading to that insomnia. Some of these could be life events, as you mentioned. Those ones, once we manage it, the person can, go back. And those ones may not necessarily require, let's say, medical or let's say drug intervention. It could be just some, psychological interventions and so on. And then the person is able to cope with the stressor and then get back to normal sleep.
Okay.
Yes.
Right. 22 minutes past the hour of 2 on Joy 99.7 FM Ultimate Health. We're talking about sleep and sleep disorders. If you have any questions, concerns, experiences, confessions, you may want to share them with us shortly. Or let me just do an early one, since we started late and it's a part 2. 030-221-6541, 030-221-6541. Those are the healthy buttons to push to get your own, let me say, sleep specialist or sleep consult on radio today, okay? Dr. Samuel Asomeni is a senior physician specialist, am I right? Yep, and he's also a resident in respiratory medicine. This has to do with your system, right? And sleep falls under that. We also handle it under psychiatry, psychology, and all that as a state of consciousness, okay? Indeed, when we put you under anesthesia, we're actually playing games with this whole cycle, but hey, we must be able to bring you back. So yeah, consciousness is a big thing, but sleep is a state of semi-consciousness, managed operated by or controlled by the brain. All right. So we're talking serious stuff here. 055 1111 997 and phone line is active. So Doc, with insomnia, anything else we want to say about the characteristic features?
Right. So it's maybe a combination of things. As we said, somebody may struggle to sleep, but once they fall asleep, they can't also maintain it. After just a few hours, they are back and they can't, get back to sleep. So we have some people who struggle to sleep and they only fall asleep towards the late morning.
Okay.
And they realize that it's time to get up because work is here. And then the consequence of inadequate sleep and sleep deprivation then continues the next day.
Okay.
And some people also, yes, they fall asleep, short period or maintain uninterrupted sleep, but may not be able to, maintain the number of hours that is desired for that particular age group that we mentioned.
All right.
But sometimes we trivialize that, and when it becomes persistent, then as we said, there's always, need to seek help rather than just endure it.
Okay. So now we're coming to the help, right?
Right.
Should you assess and determine that this is actually a significant sleep disorder and indeed insomnia, what are the steps you take?
Right. So we talk to the person. You want to really look at the events. Okay. When does the person go to sleep, for instance? All right. And then how long has that particular report been?
Okay.
The complaint, how long has it been?
Okay.
And any events in the person's life relating to this, or who could have been a precipitant.
So you're taking a whole history.
Yeah, so we need a whole history.
Right, okay.
All right, about did they have any underlying medical conditions? Are they on any drug? Are they on any prescribed or even over-the-counter medication? Do they have some life, styles?
Okay.
Some people take certain substances and so on.
Okay.
Are they taking those substances
so
close
alcohol
to bedtime?
use, for example,
very, very important.
Medications you're taking.
Right, and stimulants, coffee, and
Okay.
so on. So you need to take a whole history and then be able to know what may be precipitating this particular.
Right.
For instance, assuming in the circumstance the person has been bereaved or the person has lost some valuable thing, then this is a precipitant, and you know how to direct that particular problem. So you need a whole history. And in fact, insomnia, that is the main thing, because you can't just use any metrics to go and just measure, go and do this lab test.
Okay.
It is about talking to the person.
And getting the profile and the presentation.
All right. And they are a very good sleep history and behaviors, how is the bedroom like, what do they do, and so on, in the run up to the bedtime and so on. So that you'll be able to get a very good picture.
Before you even start fixing anything.
Definitely. So it's not the solution is not I can't sleep, just go get meds. And sometimes that's how we overlook what may be precipitating significant insomnia.
Right. I hope you're hearing that, folks. Before we start tinkering with your sleep, even pharmacologically, there's a whole range of things we need to consider. When do you sleep? Do you have a healthy sleep pattern? Do you live next to a nightclub or a church or a public toilet? What kinds of things could be giving you those or triggering the challenge you experience? How long has the challenge been there? Oh, it just started last week after I lost my husband, right? Then there's a context before you start fiddling with it or thinking that you should be popping some tablets. All right. And that's what I'm discussing with Dr. Asomani here. We're looking at sleep and sleep disorders, and we're hoping to break them down in terms of the types, their presentation, their characteristic features, and then the management. What do you do about it? I know many of you will call and say, we've been on management for a long time. It hasn't changed. Maybe some of those precipitating factors are still there. Maybe the things that are triggering the sleep challenge are still active, right? So a proper investigation, right, of your sleep and the context in which it occurs or doesn't occur is what Doc is talking about. 030-221-6541. Those are the healthy buttons to push, especially if you're awake and you can hear us. We're talking about sleep. Is it bedtime or battle time for you? Many of you like anajuede, anajuede, because yes, you call people who are sleeping and you ask them first thing, wada, because you cannot sleep. Why are you calling me 11 and whatever? And then you say, Wadana. No. These are the kinds of things. Call us and share, and then let's see if we can get an understanding of the steps. Now, Doc, Before we again tinker with medications, what are the non-pharmacological or non-drug interventions we may want to consider?
Right. So we want to look at the behaviors and patterns that,
Joy,
augment
99.7
good sleep.
FM.
Very, very important.
Okay.
All right. So, for instance, usually because we said that there's an internal clock that tends to regulate this.
Okay.
You always want to keep a certain pattern of sleep. So usually we advise that you go to sleep at almost always at around the same time.
Okay.
So that the clock is aware and the brain is not really, thrown off gear.
So what you're saying, Doc, sorry, but
Yes.
you're saying there's a software, there's a
Yes,
program that
yes.
operates
and
this.
it's used to a certain
It's
pattern.
used to, and it will fix itself to that pattern.
Definitely.
That pattern can be interrupted. But you're
Definitely.
saying we should be deliberate about sleep, right? We should be deliberate. We should plan and fix the time we go to sleep.
Exactly.
It should not be accidentally on purpose.
Yes.
Sleep should not be an accident.
Yes, so it should be a plan thing,
Okay.
and you should be deliberate about that my sleep time is this time. So
Mm-hmm.
around that time you go to sleep, and even when you get up from bed should be planned so
Okay.
that almost always, and then the internal clock gets used to that.
Okay.
And
Can
then-
I say, Doc, then
Yes.
that this cycle, though internally or innately programmed, is also learned?
Yes, you can, because you can reset it.
Okay.
Yes, you can
Right.
always reset it, and,
Okay.
and therefore it also depends on the practices that go on before or during or even within the bed space,
Right.
the sleep space, what exactly go on there. These things would all be very important. So, for instance, what does a person do before he goes to sleep?
Okay.
And when he goes to sleep, what happens in the bedroom? So we always want to say that your bedroom should be
Okay.
meant for sleep and maybe relations with your
Right.
loved one.
Okay.
But it shouldn't be like an extension of your
office.
or of your office, because so that when you get there, the brain itself
The
knows.
brain has a cue.
That's right.
That when in this situation, this is where we sleep. Okay.
Definitely.
Let
So,
me
yes.
quickly, Doc, take Kwesi, who's been hanging on the line. Kwesi is calling us from Sweden. Kwesi, good afternoon.
Good afternoon, Nortey.
Thank you for waiting. Please share with us.
Nortey, for the past close to about 18, 20 years now, I have not had quality sleep. I sleep 2 hours the whole day, sometimes 1 hour. And then when it happens like this, when I wake up the following day, I experience a lot of sweat. I sweat a lot. And then experience severe, even though I'm experiencing numbness around my leg and then my feet for the past 15 years now. When it happens like this, it becomes more severe. And then I don't know. It's like I've conditioned myself in a way that I'm in a they call it copper house, and then the bathroom is just one. And then when I take my bath, I spend close to about 1 hour in the bathroom. So I prepare my mind in the sense that I have to wake up, probably around 2 o'clock, so that I'm able to take my bath before anyone else is wake up.
Okay.
And then I've tried different modus operandi, like using jazz, to make me sleep, and then exercise in the evening. But still, it's something I'm working on. Unless if I travel. If I travel outside Stredu and I come back, I do have sometimes 4 hours sleep. When I have 4 hours sleep, I am okay. All what I've been experiencing, sometimes become very less.
Okay, Kwesi, let me ask you. You say this has been ongoing for about 15 years. When you travel, is it that you sleep better away from home, or you sleep better when you get back home?
Back home.
When you get back home.
Yes.
Okay, let me pass it to Doc, and let's see what he has to say. So, Doc, this is he says he's a diabetic for about 15 years plus. He's had challenges with sleep. He wakes up. He has to wake up and use the bathroom because it's a shared facility and all that. This has been his pattern. He struggles. When he goes away from home and comes back, he finds some relief, but then it resets itself. Any comments on this?
Right. So we need to listen to him more, and then see, for instance, what medicines he's taking. Are those medicines making him or affecting or contributing to this?
Okay.
And that how many times, for instance, does he get up to pass water when he sleeps? Some
Okay.
diabetics,
Yeah.
because of the condition is get up frequently, and
Right.
that interrupts their sleep.
Right.
And that means that we need to make sure how controlled is the diabetes.
Okay.
The diabetes gets controlled. You may not be getting enough frequently to pass water. And then we need to look at the circumstances of the, he says it's in a compound house.
Yeah.
Is it a very noisy environment?
Right.
And so on. So all those things will affect his ability to sleep and what really happens around sleep and so on.
Okay.
Right. So that he will be better helped.
I have Ajiman Joseph on the line. I'll take him quickly, Committee 9, Tema. But I'll be asking you to hold on to this question and thought that in a case like Kwesi's, would you perhaps intervene and look at a modification, if necessary, of his medications and other things related to his physical condition, the diabetes?
Yes, so the underlying condition...
Let me just take Ajiman Joseph and come back for that. Hello, Ajiman.
Yeah, boss. Good afternoon. I hope you're doing well.
I'm well, thanks. Share with us.
This is a very important topic. There are some issues that the doctor is mentioning. It's good for me. I'm the kind, I do go for road on, I go to the road for jogging 3 times in a week.
Okay.
So if I go to bed and the day I will go for jogging, I have to set off 5 o'clock. Apart from that, if I'm not going for jogging and I'm not going to work early, then I have to wake up 6 o'clock, which means the sleeping patterns or the timing changes. So, is it wrong or is not? Is there something that's not going well? And also, do you have extra sleep like after 5 o'clock, which is the normal sleeping time, and then I decide to sleep extra? Is it also bad, like from 5 to 6 or 6:30 thereabouts?
Okay, right. So he's talked about jogging, right, and how it impacts his sleep. Then at the tail end, he was asking if you want to sleep a bit longer. Right. After the time you've done your recommended, let me call it dosage, but he wants to sleep. Is there anything wrong?
There are some situations where the person wakes up and he feels unrested. Sometimes we have to question, when did he go back to sleep the previous day?
Okay.
All right. So if he has slept good enough hours and he still feels unrested, then we have to look into the quality of the sleep. How many times, for instance, does he wake up? Does he snore? Does he have problem? Does he struggle? Like, for instance, if there's a bed partner, to give us an account during his sleep, so that we'll be able to see whether there's a need to sleep on, whether it's because during the sleep the quality was disrupted and so on because of...
So is he sleeping a bit more because he's not fully rested?
That's
the question you're asking.
Yes.
Okay, but if it's just a choice,
if it's a choice because he has nothing to do the next day, fine. But if it is because he's not rested during the night and in the morning that he wants to wake up, that is when the feeling for sleep has come. That one we have to look into.
That one we need to look
at. That's all you mentioned the last time. The sleep hygiene had to be really looked at.
Okay,
yes.
Right. Oti Boateng from Tema. Good morning. Good afternoon, Oti.
Good afternoon, Oti.
How are you?
I'm okay.
Yeah, go ahead.
For me, this is always good for me. If I sleep any 6 hours, it's good. But sometimes weekend, because sometimes nowadays I sleep 6 hours, but weekend I can sleep like 2 hours more. Like they say that you have to have some nap, but because of my weekend have a nap. But if I haven't sleep 6 hours from Monday to Saturday and Sunday, I can sleep like 3 hours to add in my sleep. So that's why.
Okay, so you're getting less sleep over the weekend.
Yeah, the days the weekend have like 6 hours.
Is it because you have things to do, or that? So you are intentionally restricting or limiting your sleep to 2 or 4 hours?
No, my hours are 6 hours.
Yes, I'm just... Oti, what I'm trying to understand is that are you deliberately sleeping less over the weekend?
Yeah, because of my work stuff like that.
Okay, all right. Okay.
We can have to like to take 3 hours to add it.
Okay. All right. Okay. So he's actually tinkering or manipulating his sleep. I think if I remember rightly, OT sews.
Okay.
So he says weekend he tries to do a bit more work, so he sleeps less. And he's asking if there's a problem with this. During the week, he does his best to get his 6 hours.
Right. So, for instance, if it keeps accumulating. Definitely, there's going to be sleep deficit incurred, and nature will always find a way that you pay for it. How does it function the next day, for instance? So for instance, if it's just a weekend and the next day, does it function well? Is he able to do the things that he does?
Okay.
These are questions. But once upon a time, if you just kept one away, it may not be too much of a problem. But when it becomes very cumulative,
so over time
you have the body will
you have a debt to pay.
The body will tell you, I can't take it.
Okay.
Yes.
Sleep debt sustainability.
Yes. Yes.
You've got to manage it. Good afternoon, Nortey. How are you and your invited doctors? I think this education must be done continuously. No, I think this is an old message. Sorry. Good afternoon, Nortey. How are you and Doc? Please, is it good to go for tablets that can help you get sleep if you are not getting when you go to bed? So Hayford has moved us to the drug intervention. Hayford in Bato. Let me read a couple more and then come back to you, Doc. This one says, good afternoon, Nortey by nature. That's what you wrote? Okay, you wrote Nortey by nature. Please ask Dr. Samuel, can good sex contribute to good sleep? This is from Nana Ekua, right? Those of you who think it was from a man, right? Nana Ekua, Matthew. She intentionally calls me Nortey by nature. It's Nortey by nature. Let me come back. This one says, what does it say? Please, I stay awake for long when I want to sleep in the evening. Anytime I sleep in the afternoon, is everything all right? Ni in Dakuman. So he takes a nap in the afternoon and he finds it affects his sleep latency at night. Okay. Right, let me see if I can clear my desk here. Hello, Nortey. I go to bed around 1:30 a.m. and sleep to 4:30 a.m. from Mondays to Friday.
Wow.
Could it be a problem I don't know of? I am a 54-year-old woman. This is from Grace. So she goes to bed at 1:30 a.m. I'm not asking what she's doing and why she's up, but she's got her schedule. She's fixed it. Does she have a problem?
Right, you see, 3 is too short, and definitely
3 hours sleep.
Yes, and over time, if she would tell you, she may doze off during the day. It may affect you, put yourself at risk.
Okay.
It depends upon the work that you do, and if you drive, definitely it's going to be a challenge.
Okay.
Sometimes, road crashes and so on.
Right.
Yes.
Okay. There was somebody else asking about tablets, going for tablets. Hayford. He says if he's not getting the sleep, can he not just go? I mean, this is a known sleeping tablet. That's what people say. And very often, I'll chip this in, many people are on medications, and because there's some subjective impact on sleep, they call it a sleeping tablet when it is not.
Yes.
But this business of going for a tablet over the counter,
that is not a good practice. We need to know why you are not sleeping.
Okay.
And sometimes it's just because of certain behavior patterns and certain practices that could be modified to improve sleep.
Okay.
Yes. Some people are just keeping too much time on screen time, and those things probably could be suspended, and
Okay.
you have good sleep later when you go back.
Right.
Yes. So sometimes we could just look at what happens in their life and then modify
And
that.
clean that up.
Yes,
Okay.
yes.
Right. Someone says I take a nap in the afternoon, I will struggle in the night.
Right. Yeah, so such a person, if he wants to take a nap, it should be earlier in the day rather than later in the day.
Okay.
And it shouldn't be long enough. Usually we say maybe 20-30 minutes early in the afternoon, better than, taking a very long. Because if you rested so much,
Right.
you may find, especially in the aged people who are maybe 50 years and above,
Right.
may be difficult getting a very good sleep in the night. So if that is a problem, and he usually benefits from the nap, it could be earlier than later. And
Dog,
you could
be
keep it
careful
short.
who you are calling aged. Hello, Nortey. I'm really enjoying the discussion. I am hypertensive, but the highest sleep I have ever had, perhaps a week, is 6 hours. But during the day, I can be very active. When I speak with my doctor, she says it is stress. I am an IT professional and spend most of the time on my screen most of my time on screen from my laptop and my phone. I really think I need sleep, even though my doc sometimes advises I take medications to help me sleep. This is Kweku Nadenta. Right.
Yeah.
What do you say?
Yeah, so definitely he has pointed to the problem. And if he could settle his time to still work and have good sleep, that would be the way to go.
Okay.
Rather than say depriving yourself throughout and then just keeping a certain, just because you are
Right.
professional. Yeah. So
Right.
he has to manage that thing, and probably there's a way he could go about it.
Okay, he
And
needs to look at that, and he
yes,
needs to get help.
yes.
I forgot the name again, in Adenta, right? But on my side of the microphone, the psychologist side, not just the presenter, Kweku, we talk about competing behaviors. Anything that compels you to increase your vigilance and stay alert is going to compete with sleep.
Definitely.
Right? We have a saying, the wolf and the lamb can sleep together, but one will not be sleepy. So your work is actually
Very
competing
important,
with
yeah.
sleep, and that needs modification. Sometimes
yeah.
you do need professional help for that. Good afternoon, Nortey. Please ask your guests, scroll, how he will respond to the fact that some prayer camps say that sleeping too much is satanic. Some prayer camps, all right. How can one balance this saying with enough sleep? Ama from La. Hey, run away from those camps. Well, these are things that people do, and they do typically present in our, should I say, jurisdiction or
Definitely.
domain of practice. People are religious. They go for all nights. They go to camps, and this is what they're being told. What do you say, Doc?
This is very erroneous, because after all, God
Are you
himself...
challenging this?
Oh,
Hey.
I mean, the Holy Book says that even God gives his beloved sleep. So God himself knows that sleep is good. So if somebody says if you sleep too much means what? If
Okay.
you're having good sleep, let's say 7 hours, is that what he's describing too much?
Satan has given the threshold.
Otherwise,
But
sleep
if you're
is good.
religious,
Yeah.
Doc, and you believe this, your beliefs can also affect you.
Definitely. What do you think? And that's why sometimes we refer the cases to you.
Right. That's why we have the
and some
cognitive
people, their
behavioral-
sleep,
Yeah.
very good. Some people's sleep problem is not medicine. It's just about talking to the professionals.
All right.
And so that they can reset, in the way they think and how that affects their sleep. Yes.
Okay, right. And also, of course, sometimes when you're not getting enough sleep as well, it brings on or makes you more vulnerable to some of the other conditions.
Very well.
Right? Mental health,
Yes,
and physical.
depression and so
Yeah.
on.
Okay. Good afternoon. With regards to the discussion going on in the studio, which has to do with sleep disorders, kindly. Oops. Where did it go? All right. Okay. Do finish your submission there. Looks like your sentence was truncated. Good afternoon, Nortey. Please, my children wake up. Where is it? My children wake up early from Monday to Friday for school. Can this affect them in the future? They usually doze off when they are in the car to school. All right. Seth in Apollonia. Right. Okay. We wake up kids depending on when water flows,
It's a
the
problem.
traffic and all that.
It's
Could
a
we
problem.
be damaging the children?
We may be, and otherwise, then what we can do about this is that probably we let them do, their chores or homework early and go back to sleep early, right? Because some children, because of where they are coming from to
Right,
school,
the
have
commute.
to wake up around 4 o'clock.
4 a.m.
4 a.m.
And that's when water starts to flow.
Very well, and we know that sleep is good for the development of the mind of kids, and
Right.
that is when they even grow. So when that happens over a long time, it can affect them, and they may have all these stress-related disorders and so on. And sometimes, when they are misbehaving,
Right.
it's because of their reaction to
The
the
build-up.
built-up stress.
Right.
They're stressed. Because we depriving them of sleep, and one of the things that happens that it affects people's, the way personalities,
Okay.
the way they behave, and they sometimes become aggressive. How they respond to their neighbors,
Right.
So
But the
we
schools
need
are
to-
also piling them with tons
I
of
know,
homework.
I know.
You see the work and
I know.
the stuff even a class 2, class 3 child is doing.
I know we are all,
So it may have an impact.
Yes,
A
over
negative
time,
untoward
over time.
impact.
Over
Right.
time.
I have a call on the line. Hello?
No, no, I like something that was from Sema.
Yeah, you.
Yeah, my wife, something is sleeping. You sleep normally, like 10 o'clock, but she's sleeping, but when you call it or something, has something noise, you wake up. You cannot sleep within 4 hours or 3 hours before you sleep. If you have any noise, you can't sleep again. That's what he's doing.
Okay. Right. So his wife wakes up easily awakened when she sleeps. She sleeps at a normal time, but if anything disturbs her, she wakes up and it's difficult to get back to sleep. He's wondering if this is a problem.
Right, so she will have to look at the environment. What are the distresses, things that distract her, so that, you know, if she has opportunity to be able to modify those ones, that would be very useful. For instance, is it people making noise? Who are the people making noise? Is it something under her capacity to control?
Okay.
Is it that somebody puts on light? Some people are very sensitive to light,
Right.
and when they are sleeping and you put on light, you know, so is there something that can be done about the sleep environment?
Okay.
So this she has to really look at.
Okay, and we're praying that if you do identify those factors, they are within your locus of control, things you can do something about. But things like temperature, ventilation,
Very
lighting,
important.
and so
Very
on,
important.
you need to consider those as well.
Yes.
030-221-6541. Those are the healthy buttons to push. We're talking about sleep disorders. Doc, let's talk a bit about the medications.
Right.
We know you can modify, and there are programs that help you bring your sleep under stimulus control and so on and so forth. We hear that don't have TVs in your bedrooms and stuff. It's become fashionable,
Yeah.
right? But too many competing activities rather lead to hyperarousal,
Definitely.
which keeps you alert and awake and
Yes,
vigilant rather
yes.
than allowing you to drop to sleep. But when it comes to medications, what do these sedatives do?
Well, so some of them they work differently. Some of them, true and true, are not necessarily, let's say, sleep tablets.
Okay.
But they have the effect to ease out sleep so that you can sleep.
Some are what we call the mild anxiolytics. So
Yeah,
if there's
so-
any anxiety,
Yes, so for instance,
Right.
you realize the person's, you know, stressor or what is predisposing her to that is a bit anxious.
Right.
Right. Despite the fact that maybe she had, you know, cognitive behavioral therapy is still
Okay.
anxious, and maybe a mild anxiolytic
Okay.
here and there.
Right.
And it's not supposed to be like a way of life.
Okay.
You know, usually we give it
Short term.
Short term. Whilst we try to, you know, use other means to get the person to sleep.
so what we're saying is that if we lower your anxiety,
Yes.
should it be in, for example, in response to stressors,
But-
right?
Yeah. So
that will open the gate for sleep to
to
follow
come naturally.
naturally.
Yes.
So that
Yes.
anxiolytic or that medication we are giving is not really pharmacologically, it's not really a sleeping tablet.
That's right. So it's just
It
to
relaxes you.
yeah, so that you can, you know, you
Okay.
can catch sleep.
We are
Right.
deliberately avoiding tablet names. We know you guys.
We're not mentioning any
Stubborn
name,
Academy
yeah.
people.
And
yeah. So
and some of the medications, you know, maybe the doctor gave it for a short course, but because the person thought that it helped, he will keep on to it and realize that some of them you get tolerant to it. Your body gets used to it, and so if it give a certain measure, you may need to go up
right.
to get the
you
same.
find yourself taking
and
higher and higher doses or strength.
and it comes with other side effects.
Okay.
And sometimes when you want to
99.7
stop, you can't
FM.
sleep at all.
Right.
You know, so they may not just be without side effect, and therefore it has to be monitored by your doctor.
Okay.
Don't say the doctor gave it to me once I had this problem, and then you keep yourself on that.
So they should not be procured over the counter.
Ideally, they are not supposed to be.
Right.
You know, but you know, who monitors who? So sometimes over the counter drugs or drugs that are prescription drugs are even sold over the counter.
Okay.
Yes.
Right. Please, my mom has Parkinson's disease. She does not sleep in the night. Only 5 a.m. before will she close her eyes. What can be done? Richard in Medina.
Right, so this is a problem.
Yeah.
Sometimes, that type of condition
Right.
affects their sleep-wake cycle.
Okay.
Yeah, so some of them are able to catch good sleep during the day, right? In which case, during the night, it's like they have sleep reversal.
Okay.
Okay, so is this person able to sleep during the day, or throughout the day is unable to sleep? And it means that you have to talk to
Yeah.
the doctor who have been taking care of
Okay.
him. And some of the medicines also are able to make them have sleep. Some of the medicines that are used to
Right.
treat also are able to make them sleep. So they have to talk to the physician taking care of them.
Okay. Right. You handle this in, let's say, collaboration and conjunction with your physician,
Very important.
knowing that there's another condition you are treating, right? And
Yes.
parts of your body's response to that condition may include the sleep challenge that you have. So you're not doing this in isolation. So what about a person who's been on it for quite a while and feels, look, doc, yes, I know I have Parkinson's and other things, but the sleep is not coming?
Right, so we'll look at that, and that's why I said that there are different classes of medications that can help the person.
Okay.
Have some sleep. Right, it may not be in through and through what we call sleeping tablets. Okay, but there are certain medicines that could, for instance, help this particular man with an underlying condition.
Okay.
So that he can have sleep and not just stay, undesirably keeping awake in the night.
Okay,
Yes.
Doc, I was hoping. I think Richard has added feeding and medication disturbs her day, right? So it's difficult. It's a difficult balance.
Very well.
Many people, whether it's cancer, Parkinson's, and other
Yeah,
things,
yeah.
are balancing a buffet of medications.
I know.
And some of these medications can also present or lead to or trigger sleep challenges. Am I right?
That, you are right. And sometimes even when you have to wake up to take the
Joy
medication. and so on,
99.7
So if those things are becoming a challenge, then sometimes we talk to the doctor, because some medicine may be taken once a day. You may not need to take them multiple times. Right? So when that becomes a challenge, the doctor will have to look at that.
Right.
And then, for example, medicine taken gives you the air to pass water
Okay.
every now and then the night. There are some ways we can go about it, and therefore, eliminate that concern.
Right.
So sometimes we can let you take it at a certain specific time during the afternoon, rather
Right.
than taking it close
Might
to.
change when you take it.
Definitely.
By so doing, we are managing the challenges you have with the medication.
Yes. Because if the medicine is so important, we cannot just withdraw. We
Okay.
can just tweak it around and see it doesn't, disturb your sleep too much.
Doc,
Yes.
this suggests a lot of good, meaningful communication between patient and the doctor. I'm not too sure whether to ask whether this pertains in all cases, but what we're saying is that if you are reporting your challenges, then they can be addressed, right, by the professional.
Exactly.
If you're not, then we get the situations where people default. They're actually not taking the
Yes,
medication.
and because they have a challenge.
Right.
So sometimes we also prescribing it have to look at it in context. This person, the age of the person, underlying comorbidity,
Joy
the need to take it at a certain time, and knowledge about the side effect of the particular, and how that particular side effect can disrupt or interrupt with their quality of life. We have to look at all that.
Right. Okay.
Yes.
So you're a partner in this instance. Okay, and so you should be able to express your experience with the medication, and then also be able to describe. Many are encouraged to keep a sleep diary.
Exactly.
Right, that notes down all the important features that may manifest. My second question is about. Okay, this is from Hayford in Bato. Newborn babies who are asleep, should I say, during the day, and even at night it continues till evening, and sometimes their mothers wake them up to breastfeed them. Is it good for them to continue sleeping, or their mothers should wake them? So we're taught about feeding on demand, but Hayford has learned, well, babies sleep a lot more. Okay, sometimes the mothers wake them up because they are worried they haven't breastfed or whatever. Is this right? Are we disrupting the sleep cycle?
Well, they usually don't have challenges, especially infants, those who are less than 1 year. Right. So that is a pattern, and averagely, they will be sleeping close to about 19, 18 hours a day.
Right.
And that is their life. That is fun. And so they, of course, you will not allow them just to sleep off like that. So they will, of course, be interrupted to feed, but they usually don't struggle going back to sleep. Some of them will even fall to asleep on the breast,
on the nipple, right?
Yes,
that's
yes,
right.
Yes. So
Nice place to sleep.
it's a normal way for them. Allow them. They need it to grow.
Okie dokie.
Yes.
This one's from Clement in Takradi or Tadi. He says, What is normal in terms of sleep pattern reversal in pregnancy? Pregnancy is a bother.
Yeah. So sometimes
when it comes to sleep,
some people begin to sleep too much during the day and or during the night, and some people it disrupts their sleep a bit. It varies from person to person, but usually it's pregnancy is for a certain period, and normally once that pregnancy is over, you're likely going to go back to your pre-pregnant sleep pattern.
Okay. All right, listeners, bear with us. We're running out of time. There are some other quite common sleep disorders, we'll find a way of accommodating them. Let me just wrap up by asking Doc this. We know that when we manage some of these sleep disorders, okay, we've been talking primarily about insomnia
today, right?
With medication, there are some who, as soon as the medication is reduced or taken away, they have a rebound. The problem comes back bigger and badder, right? We tend to call this rebound insomnia, but what causes this and what can be done about this?
Right, so as I said, depending upon the mechanisms of that particular drug, some of them could not just be taken off. And even if you want to take them off, as you said, you may have to begin, and sometimes the problem of rebound and so
you
on.
Try to wean them off.
Definitely.
Okay.
So you have to know for how long am I going to put this person on this particular medication. That will influence the class of medicine that you may choose.
Okay.
Because some of them are, as I said, meant to be taken for just a short course.
Okay.
Especially, the anxiolytics. So they may be taken for a certain period. And some of them, your body will get tolerant to it. And so it's like you must need it to be able to fall asleep.
Right.
And that becomes a problem.
Okay.
Yes. And
so that's a dependence.
and that is why sometimes we have to look at, addressing this problem not just with drugs alone. If you look at the history, and the person needs to see a clinical psychologist, why not? You let the person go see a clinical psychologist, maybe talking to them, making adjustments.
You can achieve relaxation with exercises rather than anxiolytics.
You can.
Right?
So we need to know that it's not all about drugs.
Okay.
Sleep goes beyond just getting something to knock me off, right? Because it has also effects, and especially at the time that you want to come off it, sometimes it may be difficult.
Okay. Let me steal a few minutes to ask you, Doc. These are medications, right? And the class of medications we're talking about should not be over the counter. The situation in our country is something else. People pop in and out of pharmacies, chemical shops, and they procure these things, and they know the names and they use them. What would you say? Because sleep is quite a big problem when it comes to self-medication. Right, because people buy these things and it says, you want to sleep, you get this. And there are many, I consider a lot of them strong but ethically wrong advertisements, right? And things that promote this self-medication. Just a word on that when it comes to sleep, especially sleep medications.
Right, so I think there should be a number of things. The control mechanisms, are we really living up to it? And are people following it? Because sometimes every jurisdiction that sells medication and the kind of medicines you allow.
Okay.
And some of them know that they're supposed to look out for the prescription.
Prescription only, yeah.
But, we don't do. So I think we should not just look at dishing out medicines to people just because we are selling our medicines anyway.
Right.
But we may be, worsening the applied in the long term. So I think, as you mentioned, ethically, does it sound right? Just because I get my medicine, regardless of the age of the child or of the person coming to demand a particular medication without really demanding the right thing being done. So I think we should learn to do the right thing. In certain jurisdictions, you will not be able to ask for certain drug.
Yeah.
They will not look at your face.
And they will not even dispense
They
it
will
to
not.
Right.
And why can't we do it here? We probably can
should be
enforce
looking
it.
at
Yes,
that.
we
Okay.
should be able to do it here.
Right, this has been great. We still have arrears when it comes to sleep apnea, a situation where your breathing stops for a brief moment and you struggle to get your respiration back. We talked about the sleep paralysis last time, where you wake up and because of the stage of sleep or the type of sleep you are in, there's a certain paralysis for a brief moment, but you may become anxious. Some will call their pastors and things. We explained that last week, but essentially these are things that are understood and can be properly and professionally managed, like Doc is saying. When it comes to medications, please, pretty please, with sugar on it. Yes, please. A doctor, a qualified doctor will know when he's giving you the medication and in what dose, and also how long the effects will last. If you are treating yourself for self-medication, you may cross over the next day with, should I say, residual effects of the medication. You are driving, you are doing many other things you shouldn't be doing under that medication. Your doctor will know that. I see Doc is nodding to that. So when you're tinkering with it, it is quite convenient to just purchase these things. But in this case, convenience may be a curse.
Exactly.
And that is why each and every Sunday, we bring in the professionals, the practitioners, to inform and transform so that we make sure we're doing the right thing. We'll see if we can squeeze some time next week to talk a bit more about some of these disorders. But many thanks once again, Dr. Someni, for sharing your rich experience with us. This one, it says,
thank you very much.
Kwesi Nadenta, Nortey, I joined the security service, went for a paramilitary training where I woke up at 4 a.m. for 8 months. And for 24 years, even if I sleep at 3:30 a.m., I wake up at 4 a.m. What should you do? Have you left the service? But there are things you can do to relearn and reset.
Yeah.
These days, that word is sensitive. But yes, it can be, it's the same way your brain has learned to sleep at certain times. And when you cross a time zone, you have what we call jet lag. So we need some resetting for you. But I appreciate you sharing that, Kwesi Nadenta. All right, it's time to leave. Stick and stay on Joy 99.7 FM. Ziggy Bedu comes up with some good music, which is also good for sleep. Good music, but don't sleep such that you slip the dial. Keep it on 99.7 FM. My name is Nortey. By nature, I'm out.
All right. Thank you.
The higher you build your barriers,
Joy 99.7
the
FM.
taller I become.